To request our next speaker, Dr. Vishal KISHORE, who will be speaking on Topo and tomography are important for premium IOLS. Dr. Pooja Sinha, can you please join us at the chair here?
Good morning. So, coming to my talk on importance of Topo and tomography in premium IOLs. Now, in premium IOLs, such as toric IOLs, multifocals, EDOF, these has resulted in paradigm shift in the cataract surgery. Cataract surgery is now just not treating the disease. It's basically optimizing the refractive outcome as a refractive surgery. And the onus of giving a 100% result means patient expectation is very high, and onus lies on us as a refractive cataract surgeon. So what is topography and tomography? Topography basically measures the shape and optical property of the cornea, while tomography gives a three-dimensional section of the cornea for the in-depth analysis. Now suppose if you're planning premium IOL, does the routine examination with slit lamp, detailed fundus examination with indirect colposcopy and keratometry will suffice our preoperative assessment? The answer is big no. And especially in the era of refractive surgery with premium IOLs in our armatorium, visual recovery after cataract surgery for eyes with irregular corneal astigmatism may not be as good as expected by surgeon and patients. So first we have to evaluate corneal irregular astigmatism and optical quality of cornea in patients undergoing cataract surgery. Then based on these findings, we have to give options to our patient for various premium IOLs available with us. So for this purpose, topography and tomography is important. So corneal topography basically helps in detecting ocular surface disorders, as myas are highly sensitive to irregularities of precorneal TFL. And ocular higher order aberration have indicated aqueous deficiency or evaporating eye disease for fluctuating vision quality. So even the American Society of Cataract and Refractive Surgery, they have proposed algorithm to diagnose and treat significant ocular surface disorders before any refractive surgeries. Apart from this, the size and location of pupils should be within normal range to avoid post-operative symptoms like halo, glare, and dysphotopsia, especially when we are planning IOL multifocal implantation. So coming to the evaluation in case of toric IOL. Now toric IOL corrects, we know it corrects corneal regular astigmatism, but it should be best avoided in keratoconus with significant irregular astigmatism. Now this is the first picture. This shows the symmetric bow tie appearance of a regular astigmatism. The other picture shows just the difference between regular astigmatism and irregular astigmatism. In the first picture, we can see again the typical symmetric bow tie appearance, while there is no symmetry in irregular astigmatism. Then anterior corneal astigmatism shifts from with the rule to against the rule as the age advances. So we are born with the rule and die against the rule. So what is this with the rule and against the rule? With the rule means the steep axis is at 90 degree, and against the rule the steep axis is at the 180 degree. The picture down, the first one shows the what is with the rule, and this is a topographic representation. Now posterior corneal astigmatism on the other hand remains against the rule in most of the cases. So nowadays toric calculator like Barrett, they uses posterior corneal curvature evaluation, and this results in a lower prediction error in their calculation. But in future, direct measurement of corneal cylinder using anterior and posterior cylinder from tomography will be an alternate method where we won't be dependent on this with the rule and against the rule adjustments. Coming to the evaluation in case of aspheric IOL, we all know aspheric IOL is designed with a fixed amount of negative spherical aberration to compensate for average positive corneal aberration. But in eyes with LASIK or advanced surface ablation for myo, the cornea becomes oblate due to central flattening, and this results in increased aberration. So for these patients, aspheric IOL is a better option. While in case of keratoconus or LASIK for hyperope, there's decreased aberration. So for these patients, we have to give an option of spherical IOL, which is a better option. Higher order aberration increases with age, but in case of spherical aberration, there's not much significance, means no significant changes with the age. So ideally, topo and tomography assessment of higher order aberration before cataract surgery should be done, because aspherical IOL work best for eyes with average corneal spherical aberration without other forms of higher order aberrations. Coming to evaluation in case of multifocal or EDOF lenses, these lenses, especially the multifocal, they carry a risk of reduced contrast sensitivity, photopic phenomena, and increase in corneal high order aberration results in decreased contrast sensitivity. So topo and tomography plays an important role in detecting these high order aberrations and patient counseling for the implantation of these lenses. Now, after refractive surgery, we have to take a decision of which IOL is best, which is suited best for the patient. So again, topo and tomography comes into use because they identify myop and hyperop after refractive surgery in spite of its absent history. And it estimates optical zone, whether it's centered or decentered. And based on the corneal higher order aberration, whether low or high, we can do a proper counseling for the IOL implantation. So to summarize, means in our SOP of preoperative assessment, we have to even include this topo and tomography, and we can do in a 4-step. First is check for corneal irregular astigmatism. If corneal higher order aberrations are high, informed consent should be taken from the patient that poor visual recovery will be after surgery, and for these patients, multifocal IOL is a strict no. Then check for corneal shape after refractive surgery, confirm the surgical history from the patient, use correct IOL formula for post-refractive surgery, check for regular astigmatism, and finally check for corneal aberration, and then go for appropriate IOL planning. So this SOP should be included in our normal pre-operative assessment for the cataract patient. Thank you.
Thank you, Dr. Vishal, for that amazing, wonderful, comprehensive